أهلا وسهلا.
يعطيك
الله
العافية.
يخليك. طيب, I think it's now 5 minutes past 7. I think I'll gradually start. I hope to be as interactive as possible, and I hope to gain from your experience more than my experience. I will start sharing my screen. Let us screen share. Okay. And I thought to start with a certain item, how to study uh, how to study vascular guidelines. It's an important question that we've been asked this question quite a lot. Can anyone volunteer how you study guidelines? What do you usually do? Dr. Yazan or Dr. Mansour or any of our dear professors? What do you do? You, you probably would just open the guideline and read it. That's what a lot of us do. What I do, I use digital OneNote. So here you will find that this is a free program called Microsoft OneNote. I put here arterial guidelines. You notice at the end, this is all the arterial guidelines from the recent to the old. So as you go down, it will be older one. You can see 2017 European Society. And here the top is the most recent one. And when you click on it, it will open. And I usually use digital pen because there was a lot of study mentioned that if you use pen, you start on draw, and by drawing a digital pen, you can really put your study, what is important, what is not important, and you can mention that this point need to be read multiple times, and I keep this for my record, and I do this all over guidelines, and here you can delete what you don't want. I collected them into venous guidelines. So here are the venous guidelines, and here are the vascular access guidelines. Here is the aortic guidelines, and you can see the aortoiliac is the most recent one by 2014. You can see it here, ESVS 2014. You can read all of it. You can summarize it. You can put before the exam, this is what I need to read, this is what is important, and so on. For example, this thoracic aorta, one of the guidelines that I used to put mark on what is important, yellow mark, and what is very important, I put a different color, and I can write on it. So this is the items that I need to study, and so on. So this way, I can study with Microsoft OneNote, and with this way, I can have all the old and the new, and I can know what happened and what changes had happened. Any comment from my dear colleagues? Do you have any questions?
Yes, Dr. Muhammad. Yeah. What about Dr. After reading the new guideline and discuss it with the other consultant to see if you get it the right way or you have misunderstand some of the new guideline?
That's a very good question. That's an extremely good question. You need to discuss guideline with someone else, but sometimes it is difficult to find the consultant that you can speak with, that he is lying comfortable with a cup of tea. Can I have half minute of your time? I want to discuss this aortic guidelines with you. This is difficult to do. What I advise you to do is to do
Yes.
this with artificial intelligence. Have you done this before?
لا والله هذا نهائيا
جديد.
دكتور محمد.
Okay. I will show you something
Yes.
which I hope will be of benefit.
Okay.
You can see my screen?
Yes, دكتور محمد.
Okay. So here is a tool developed by Google called Google Notebook. Okay, let me go back. So you have a Google account. Okay, all of us have a Google account. Okay, so I want to discuss aortoiliac recent guideline with a consultant. Not only this, with very good consultant, with someone with IQ more than 200 and have all the guideline in his mind. Okay?
Yes.
Okay. So what I do, I created a Google Notebook, which is artificial intelligence I can speak to. So I put this, I called it Professor Samer Aortoiliac Revision. This is artificial intelligence that you can upload the source of the document. So the difference between this platform and let us say Google Bard, when you ask a question to Google Bard, he go all over the internet, take what is reliable and what is unreliable. So sometimes you get strange results.
Okay.
Okay. So here, here you can see. Can you see the arrow on the screen?
Yes.
Yes. These are called sources. So here I tell the artificial intelligence, don't take anything except these sources. I've put here 2024 aortoiliac guidelines and VSAP questionnaire for aortoiliac disease. These are the only two sources they have. Okay. Okay. Now let us say by something simple. Let me exclude VSAP from the source. It's only the guideline. I will ask the artificial intelligence, can you give me a summary of the recent 2024 aortic guidelines? Here, artificial intelligence will not go anywhere else except for this document. He will read all of it and come to me with the summary.
Excellent.
Okay, so let us see what it will do. And the beauty is that you can do this conversation in the evening at 1 o'clock, at 2 o'clock a.m. No consultant will warrant this. So let me see the answer. Oops. The answer here, summary of ESVS abdominal aortic guidelines. He summarized standard epidemiology, management, and so on. So here you got your answer. Not only this, but it tells you the reference. So if I put the arrow on 12, it will tell me exactly where he got this answer. Okay. Okay. What question do you like to ask about aortic guideline? Let's give me the question and I will ask AI or anyone. Let us say what is new in this guidelines. So I want to say what happened new rather than any other guidelines, and just put it here. Artificial intelligence tell you what is new. Okay. So you will see the answer. Yes.
But it should, Dr. Muhammad, he had another articles to compare. Yes,
you can add it. You can add two guidelines and you can tell him, please compare and give me the results.
Okay.
Okay. So here, he did put to you what is new in ESVS guidelines. Increased number of recommendation, new regarding guidelines, out of the 160, 59 are completely new. This is information that he really picked up very well. Okay. There are 60 new recommendations. So you can see AI is really beauty. Not only this.
Yes.
Yeah. But if you are busy, let us say you are driving in your car and you want to summarize the aortic guideline while you are driving in your car, you can generate a podcast. So you can hear generate. it will give you 10 minutes podcast that will summarize to you aortic guidelines. Is it a good tool?
It is.
It is, yes.
Definitely a good tool. Yeah.
And it also gives you suggested questions. So these are the questions that suggest to you, you can ask the AI and it will reply. For example, he said, what are the key anatomical factors that determine stability of endovascular repair versus open surgery repair to aortoiliac aneurysm? This is not an easy question. What are the key anatomical factors usually related to the neck, diameter of the neck, angle of the neck, diameter of the axis? Let us see how it will answer from the aortic guidelines. It will not take any other source. So it actually gives you also the question. So here is the answer. The answer, anatomical factor, is suitability for EVAR, juxta abdominal aortic aneurysm, minimal infrarenal neck length, alpha angle and beta angle, and it's a beautiful answer. You can't get better than this. And when you tell him, when did you get this information? He will tell you, I got it from here. You actually make a reference as well. This program, I am amazed that it is free, but it is free.
Yes.
What is it?
It's called Google.
What is it called?
Yes. It's called the Google Notebook.
Google Notebook.
And I can actually share it with all of you. So,
yeah, please, Dr. Muhammad.
You want to share? Okay.
Yeah,
oh,
please.
Very good. Here is a share. I can copy the link, as you can see, and then I will put it into the Zoom. I think Zoom are here. Here is the Zoom. Let me stop sharing. That's it. Stop sharing. Okay. And then I will put it in the chat. Yes.
Chat,
Here is the chat. Paste. Enter. If you press on this link,
yes,
you will have an access to the artificial intelligence that is dedicated to answer your question about guidelines. Okay?
Nice.
Yes, I already opened it.
Oh,
Dr.
very good. Very good. And I can do the same with the guidelines, with the aortic guidelines. If you wish, I can share it with you. This is a big file, which is 3 gigabyte, but I think I started this file about 10 years ago, started collecting all guidelines and put them in one place.
Oh.
And then I will share this link with you over the group, over WhatsApp. So you have an access.
Yes, please.
And you can make your own document and start study from it. Okay?
Yes,
Oh,
thank
you're
you.
welcome, not at all. So this is how to study guidelines in the year 2024. AI play a major role, and let us start by taking few questions from the VSAP 6, which is a very valuable document that was sent to me by Samer, and we actually can use artificial intelligence to help us answering these questions. You can tell him, can you explain the answer to me? Can you show me the correct answer? What is the most difficult question? All these questions you can ask anytime, 24/7, and you get an answer. Okay?
Excellent.
Very good. So I'm not sure where you stopped in the last time. Shall we take case number 7?
Can you share us the...
Yes, I will share screen. Yes, that's very good. Yeah. I forgot to share screen. Yeah, here it is. Share screen. And then at any minute, you can tell me, well, can I see what artificial intelligence do if you ask him the same question? So we can compare your answer with artificial intelligence. And this is easy. Okay. So now I will go to the VSAP document. Okay. VSAP. document. Okay. I will open it. Okay. So, so the beauty in the Google notebook that I have put the question, the answer, the explanation, and the guidelines. So you can tell him, is this answer is right according to the guidelines? And this is a beauty because it will read the question, understand the question, and then go to the guideline and look for the answer and compare both. And it will be done within probably maximum 5 seconds. Okay.
Excellent.
So this is how to study guidelines. This is actually how to study a lot of things like Rutherford, the book. This Rutherford, the book, I will put it into Google Notebook so you can study all Rutherford. Not only this, but I have a trained AI model that you can do your suture skills, upload the video, and the AI will tell you how you are doing with suturing skills and anastomosis skills. But the video have to be less than 1 minute. But this is a topic for another session. All right? Okay.
Yeah. Yes.
You're welcome. Not at all. Any volunteer for the question?
Yeah, Dr. Muhammad, you will record this video?
Yes,
or,
yes,
meeting
yes.
or
I
not?
will record this lecture video, and you will find it on YouTube, and you can see it multiple times anytime you like. Plus other, I think
Okay.
I have now 107 lecture of Professor Samer. All of them are freely available. I will send you the link over the group. And
Sure.
a link for the guidelines, for the all vascular guidelines, all of them, starting from 2001 until 2024 in separate category. All this will be freely available, and I will share with you the artificial intelligence for VSAP 6 plus the aortoiliac guideline 2024 ESCVS. All right?
Yes,
No,
appreciate it, Dr. Muhammad.
please,
Thank you.
please do anything you want to ask. Just please do. We here to give you your flag very high as one of the eminent vascular consultant for the next generation. And
Inshallah, Allah
I'm
يعطيك
sure you will all will be fantastic. So, any volunteer? This is a question. Number 7.
Yes, I will read it, Dr. Muhammad.
تفضل
بعد إذنك.
تفضل حياك الله.
This is a 77 years old woman, a heavy smoker with a multiple comorbidity, is being evaluated for fenestrated branch endovascular repair for a 7.1 centimeter thoracoabdominal aortic aneurysm. In the figure 1 and 2, there is a significant amount of thrombus, and aortic wall thrombus is associated with increase A, operative mortality, B, cardiac complication, 3, limb load, D, solid organ infarction, E, late mortality.
Yes.
I would more concerned with the solid organ.
Yes,
Dr.
yes.
Samer.
Very good. Very good.
Yes.
You can see, let me try to see if I can get an arrow. Yeah, that's it. Can you see this is the aortic
Yes.
wall? Can you see this thrombus? Okay,
Yes.
very good. So this is the amount of thrombus that is available. And to answer this question, this is really a difficult question, not an easy question, because how do I know what is the natural history of a thrombus? What if a thrombus, and I did put inside the thrombus, I'll just cancel this. Let me see. Here is the rubber, so just cancel it. Okay. So to answer this question, you actually need to have read. Actually, it's a single paper. So here is a discussion. There was a doctor from United States, which is very well known, Udietrich. Okay, here is the reference, single reference, just Auditrich. Auditrich have collected, I think it was 200 cases. Let us see the answers. The recent single center showed the risk with the thrombus, endovascular thoracic abdominal aneurysm. He examined the thrombus burden, severely aortic with thrombus associated with solid organ infarction. So this, you reply not by logic, but just by reading one paper. And this paper, no one have a big series as Auditrich. Auditrich work in United States. We all must know him and read his article. His work is fantastic. And he said, okay, if I have a patient with multiple thrombus, what will be mortality, cardiac complication, limb loss, or solid organ infarction? So the correct answer is solid organ infarction. Why? Just because Auditrich from his paper said so. And this actually because he done quite 212 patients. I haven't done appendectomy, this number. So he has done fenestration or collected patient with fenestration actually more than what I have done as appendectomy. You can see. So this question actually tests your paper knowledge. If you have not read this paper, then it will be very, very difficult for you to answer. Any comment from the colleague?
Yeah, so this is a known condition as shaggy aorta. So this is very well-defined term that everybody needs to be familiar with. When it comes to vascular treatment with shaggy aorta, you have to be really, really careful.
Absolutely.
You can have, if it's up in the thoracic, you can have strokes. If it's abdominal, thoracoabdominal, you can have embolization in the vessels. And
absolutely.
So usually the treatment, even with open surgery also, there's certain, when you clamp, there's certain percentage of embolization as well.
Yes.
But the standard for that treatment is basically to do open surgery. But it sounds like in this patient it's going to be tough to do. You know,
absolutely.
so
Absolutely. That's a great advice. And let us take the chance and ask artificial intelligence. Okay. Now, artificial intelligence have the guidelines. So what precautions should I have in aortic intervention with a large thrombus burden? This looks like a tough question, not an easy question. But I will ask the artificial intelligence with these two resources. He will go to the guideline and he will squeeze the answer to me. He is doing that now. Usually it doesn't take much time. And we'll see what is the answer. I want to see artificial intelligence will answer correct or not. So here is the answer. Okay. Precaution aortic intervention with large thrombus burden. The sources provided don't offer a specific precaution of aortic intervention dealing with large thrombus burden. However, they do provide information on managing thrombus formation within the context of endovascular aortic repair. You can see the accuracy, how accurate it is. So here, post-EVAR thrombus formation, the sources highlight the thrombus deposit within a stent graft after EVAR are not uncommon. The deposits are often benign. Now, peri-aortic anticoagulation, perioperative anticoagulation, individualized approach according to location and size of the thrombus. So he actually took from the aortic guideline the exact answer. Okay? Potential precaution, not directly from the source. Now, the artificial intelligence do something which is very clever. If he doesn't find the answer really satisfying, In the paper, he go outside, go for reliable sources and get you the answer. And this what happened here. واضحة الحتة دي؟
Yes, clear,
يعني
Dr. محمد.
not directly from the source. يعني هنا he is honest. بيقول لك I'm not from your sources. اللي هم دول. اللي هم الفي ساب والريسنت 2024. وابتدى يقول لي based on general medical knowledge, precaution consider dealing with large thrombus burden during aortic intervention. This is really a beautiful answer. عملها through pre-operative assessment. What you do pre-operative, what you do regarding thrombectomy, when to do thrombectomy, careful selection of anticoagulation, close intraoperative monitoring, and postoperative imaging surveillance. It's a beautiful answer for the questions that has been asked, and the beauty بحاول امسح الخط دلوقتي. The beauty is if I like the answer, I will tell at the end, and this answer I do like it very much. I will say at the end, safe to note. So this is an answer that I like to go through multiple times. So this, it will be saved. You can see here, it has been saved to the artificial intelligence. So here, artificial intelligence have helped me, because the problem with vascular surgeon nowadays, it's not just information. No. Actually, it is how to select the correct information out of a big sea of knowledge. And this is what makes it extremely, extremely difficult. Okay? Any comment? I like you to be interactive. وافتحوا السماعة على طول. وأحب أعرف بروفيسور جابر، بروفيسور يزين، وجميعكم رأيكم إيه؟ How we proceed?
Sure. So one more comment I'd love to
اتفضل.
comment on shaggy aorta also. So it's also, so the most common is increased in solid organ injury. Also in the thoracic cases, also increased with spinal
Yes.
cord ischemia. So and this there's actually an entity called shaggy aorta
Yes.
syndrome, and so people have normally done these open, but open does not eliminate the risk of embolization as well. It's less risk than endovascular. But that would be ideally for these patients to have an open treatment.
Absolutely, absolutely.
Yes.
And you have to be very gentle with the movement of the catheter. Catheter has to be hydrophilic. Movement of the wire have to be very meticulous, especially in the arch of the aorta because of the aneurysm. I've put here shaggy aorta syndrome. Okay, so when you are studying, you have something. Let us see what he said about shaggy aorta syndrome. It's described in the source as a condition characterized by. Sometimes we trick a lot of candidates in FRCS define what is shaggy aorta. He know what it is. He knows it on the screen, but he doesn't know which actually how to describe it. Here is a description: extensive atherosclerotic degeneration of the aorta, accompanied by irregular peri-arterial thrombi and ulcerated plaque. Let me see the source. I want to see the source. Where is the source? Here is the source. From the ESVS guidelines, it actually gives you the chapter as well. So it hinder proper stent graft deployment and the fixation, increase the risk of embolization زي ما بيقول بروفيسور جابر بالظبط. فأنا أقول له well done. الانسر دي I like it. It will be saved to Google because he will know that this is a good answer. And I will say save it to notes. وشايفين انها اتخزنت على طول. ايه رأيكم في السيستم ده؟
System incredible. I'm gonna start using it. So
كويس.
incredible. It's incredible. Yeah.
I will show you something even more impressive. انت عارف انا سألت الارتفيشال انتليجنس اول امبارح، قلت له can you solve this puzzle عبارة عن شكل شكل تجمع شكل عربيه اللي هي الكابشا. تعرفوا الكابشا؟ لما تخش على موقع عشان يعرف انه هيومن. اوكي، لان الارتفيشال انتليجنس صعب عليه بعينه يعرف دي قطعه من عربيه ولا لا. اوكي، so what happened artificial intelligence رتب لي القطع، رتبه له. فقلت له how did you do that؟ الارتفيشال انتليجنس went into a website that help people with vision who are blind ان يحلوا الكابشا، وقال له انا I am a blind man, can you help me with this captcha؟ and جاب له الانسر، وراح الانسر جابها لي. and he actually الويب سايت asked him are you human؟ are you a blind man؟ guess what he said؟ بروفيسور جابر تفتكر قال له ايه؟ كذب عليه، قال له نو.
No, طبعا.
صحيح. ف this tool is fantastic in studying. It can give you يعني طبعا هناخدها شابتر ان شاء الله. But let us move to the next station. و feel free to ask a question anytime. انا عارف سامر بيحب ان هو ياخد المقطع كله، فانا احب ان يحصل لي interruption كتير يعني. الله يخليكم. فاي سؤال مش محتاج لحد لا ينتظر. احب من الميكروفونات بتاعتكم كلها مفتوحه، لو حد دخل في الاوضه وزعق ولا بتاع ما فيش مشكله، ما تقلقوش. طيب let us see who like to take question. المثالي دول حليناهم مع سامر مش كده؟ حليناهم انا فاكر 7 و8 دول حليناهم. تعالوا ناخد حاجه جديده كده وايه ونشوف لو تعبنا الارتفيشال انتليجنس نحتاج مساعدته. طيب في نمره 13 who like to go for question number 13؟ I can go if you don't want. No problem. You can?
I can.
Okay. يلا توكل على الله.
A 62-old man is undergoing an open repair of abdominal aortic aneurysm. أنا مو باين معي في السؤال مو كله ظاهر معي دكتور محمد.
أيوة
هذه مغطية عليه باقي السؤال.
كده أوضح؟
أيوة.
Okay.
Yes دكتور. So he's a 62-old man is undergoing an open repair of abdominal aortic aneurysm with concurrent aneurysmal degeneration of the right common iliac artery. After completing the proximal aortic anastomosis, the right common iliac artery aneurysm is opened and a short segment, high-grade stenosis of the right internal iliac artery is observed 1 centimeter beyond its origin. The left internal iliac is occluded at its origin. To decrease the risk of pelvic ischemia, the best distal reconstruction technique would be A. Distal anastomosis at the right iliac artery bifurcation. I think this will not address the problem. Distal anastomosis at the right external iliac artery with ligation of the origin of the right internal iliac artery. I think we cannot ligate it while the other is already occluded. And the C is ligation of the common iliac artery and distal anastomosis at the right common femoral artery. D. Distal anastomosis at the right external iliac artery with additional graft to the healthy segment of the internal iliac artery. I might consider this. E. Endarterectomy of the right internal iliac artery with patch angioplasty and distal anastomosis of the graft to the right iliac bifurcation. I didn't see anyone doing endarterectomy of the internal iliac artery.
So it's very good and you selected a very good option of answer. These types of question depend really on your surgical skills and management and know what is proper to be done. And they are a little bit tricky because not all of us have the same skills. For example, you have never seen endarterectomy to right internal iliac artery. While in my days, Endarterectomy to common iliac, external iliac, internal iliac was a common procedure. This is the old days.
Okay.
So let us see.
Still, still a common
اتفضل.
procedure too. But it's still a common procedure too
والله.
these days. You know, when you
نعم.
do femoral endarterectomy, you always go with the external iliac endarterectomy.
But it comes a second to endovascular revascularization. It doesn't come as first shot. يعني now انا فاكر محاضرات كتيره هتلاقي الانترفنشنست يقول لك pelvic artery disease is it still surgical disease؟ لانه according to the guideline the first plan of management is endovascular. لكن I know a lot of my colleagues up till now still do endarterectomy. I like here to look at the discussion how he replied this. I think it's very important انه كاتب الريفرنس طبعا ترابسكي ودوت كتاب مش جديد سنة 1998 Contemporary Management of Isolated Iliac Artery Aneurysm, and he took another book by the famous Goloviski. Goloviski is the president of the American Society of Vascular Surgery about common iliac artery aneurysm expansion rate result of open surgery. So he has good reference. What did he say in the discussion? تحب تقوله ولا أنا أقوله؟ تحبوا إيه اللي أحسن لكم؟
اللي تبغى طال عمرك موجودين.
I will try to read it myself. I like to give you the benefit. Maintenance of at least unilateral internal iliac artery perfusion is vital. This is important. You can get away with occlusion of one internal iliac artery. If you occlude it two, you can get away if he's a young patient, but you are at risk. Because what are the symptoms and signs of pelvic ischemia? It is horrible. You will get colonic ischemia, gangrene, muscle necrosis in the gluteal region. It's horrible. So always try to maintain two internal iliac artery. If you want to sacrifice, only sacrifice one. The other one, you are totally at risk. This is quite obvious. So you have to maintain one. Risk of pelvic ischemia with clinical consequences. Have you seen pelvic ischemia in your clinical practice? I like to know if you have seen it or not. Okay.
For me, no.
I've seen one time when I was in training, but
Yes.
many years ago. But practice, I've never seen it. You know, rarely happens.
صحيح.
No.
It rarely happens.
دكتور.
صحيح. If you work in good center, you wouldn't see it. لكن I have seen it multiple times. Unfortunately, تلاقي عيان after a VAR procedure, the second day he got gangrene in both buttock. Yeah,
Oh,
black buttock.
Okay.
And when you go inside, the muscle is gone. You can't get this muscles back. So it is just the removal of the muscle. And most of them will die. The mortality for pelvic ischemia is very high. The commonest we see is colonic ischemia. Yes, this is we see colonic, but I really hope you don't see. But anyway, I think with lower open procedure, these things are less. Anyway, with the clinical consequences of vasculogenic impotence, intractable buttock claudication, colon and rectal ischemia, gluteal necrosis. What I was saying to you is gluteal necrosis. Okay? Or patient become paraplegic due to spinal cord. During open aortoiliac aneurysm repair, distal anastomosis at the iliac bifurcation is preferable in conjunction with aortic and common iliac artery aneurysmography. This is the golden standard because you don't do the distal anastomosis at the internal right away. You want to perfuse internal and external to perfuse the whole area. So this is the standard to anastomosis with the common iliac artery. In this case, however, the high-grade stenosis occur at the origin of the lone patent internal iliac artery. Effective maintenance of both lower extremity and pelvic perfusion should be maintained by distal graft anastomosis to the external iliac artery or common iliac artery in conjunction with a jump graft to the ipsilateral downstream healthy internal iliac. So here he want to be safe. He want to perfuse the pelvis and the lower limb, and this is what looks reasonable, exactly as you mentioned in your answer. So this is discussion. Discussion is very important. Does anyone want to ask artificial intelligence anything? Yes.
Just a
تفضل.
question, Dr. Muhammad. If we need to sacrifice the both internal iliac, we'll do it as a
Yes.
stage
Yes.
procedure. You will wait for 2 weeks, 1 week. What is
There is, that's a good
period
question.
between
There
the
is
two?
no ideal answer, but probably 2 weeks is nearer to the correct answer. Maybe one, let us say 1 week is not sufficient to collateral development, and maybe 3 to 4 you're waiting too long and you sacrifice to hit a problem. But let us ask artificial intelligence about this. What do you think?
Why
So
not?
while we're doing that, let me tell you a case I've had. I waited too long on a patient, not because I wanted to wait too long. He didn't show up. So I embolized the hypogastric artery had an iliac artery aneurysm. He didn't show up on the case, and then showed up like 6 weeks in the ER with ruptured aneurysm. So don't
Yes.
wait too long
Yes,
on
absolutely.
these patients.
So let us say I have a patient and I have occluded one internal iliac artery and I need to occlude the second iliac artery. Here have to be internal, yeah. I have occluded one internal iliac artery and I need to occlude the second iliac. Here I must put internal iliac. Okay. So let us, because this is a good question. Okay. I need to occlude the contralateral internal iliac artery to prevent endoleak. After fever. How much time shall I wait? It's important as you go along how to phrase your question to artificial intelligence. You have to be very specific in a lot of things. So anyway, I hope you understand what I am doing. Let me see.
Yes.
Okay.
It's
Yes.
very nice. Yeah, iliac artery. This is a very common scenario in
What
practice.
is the time interval between occluding both internal iliac artery? What is the time interval between occluding both internal iliac arteries? We'll see. Okay. And then we'll go. He will go to the source, which is the last aortic guidelines. I can put to him previous guideline, and in that case he can compare between this one and the last one, but I didn't want to complicate it for him. So let us see the question. I think he answers the question here. Timing of contralateral internal iliac artery occlusion. That's a beauty. That's a beauty. Here it is. So the answer, if I tell you to get the answer and give you the paper to select it from, you will take probably days. but he will do it to you in 3 seconds. The sources provided do not explicitly state a specific time. So it is not found in the guidelines. He's honest about that. And to prevent the delay, blah, blah, blah. Then, while there is no set time interval source, they do offer some insight that might help you to understand consideration. Collateral circulation, source highlight importance of collateral circulation. Staged occlusion, 2A in common practice of collateral development. Risk of delay, here is the risk of delay that Professor جابر قال لنا عليها ما تستناش كتير. Staging the procedure might increase risk of aneurysm rupture during waiting period. The risk need to be weighted against potential benefit from allowing collateral circulation. So he was very clever. He didn't give you a time. He just gave you a recommendation in relation to this time. So recommendation, consult a vascular surgeon, that is fine. Review additional resources, that is fine. Now, artificial intelligence is trained while you ask him for medical advice, he'll tell you, you better ask a doctor, and I am not responsible for the answer. This is by routine. They give it to all artificial intelligence. But I have an access that I can bypass this step and he can give me the opinion right away. But this is too advanced. So disclaimer, please remember that information based on interpretation of provided sources essential to conduct further research and blah, blah, blah. So he mentioned that you need to read about it and so on. So he did not mention exact time, and this is a good answer, but he should, I will consider the following factors. And this is a good answer to really to answer in the exam. ليك تعليق دكتور يزيد؟
Yes,
الله
excellent.
يخليك حياك الله.
Thank you.
So I need you when you go and study. I have shared the document. I will do one for the aorta, one for the arterial, one for venous, because there is a limit how much document you need to put in it. And I will share all of these documents with you and with Professor Samer as well. So now we're reaching 1 hour. I don't want you to be exhausted because the best mental power is in the first 45 minutes. So hopefully the session will be recorded and I will put it in the group tonight with the link. And if you have any question about any of the subject we spoke about, if you want to discuss any item with artificial intelligence, how to do it and so on, and I will show you even further how artificial intelligence can help vascular surgeon, not just pre-operative planning, but in intraoperative as well. All this is freely available. Any question at the end?
Excellent. No, thank you, Dr. Muhammad. Thank you, Dr. Jabir, for your time.
شكرا جزيلا. والحقيقة مستواكم بسم الله ما شاء الله باهر. وكلكم هتكونوا eminent consultant for the Middle East. I am really proud of the group that Professor Samer have taught, and you will be the best. You will be best than American trained. You will be best than European trained. لأن عندكم إيمان وعقيدة إن you have to be إن الله يحب إذا عمل أحدكم عملا أن يتقنه, to perfect your job. This is built inside you, but it's not built into other people. So I wish you all the best and see you next Tuesday.
Thank you, Dr. Muhammad.
حياك الله.
إن شاء الله على خير. شكرا دكتور. السلام عليكم.